Well, good afternoon and welcome you all here for Ideas for Tomorrow. Few people ever heard of McAllen, Texas in May of 2009. 1 month later, it was one of the most talked about cities in America. An article in the New Yorker magazine revealed that McAllen had the second highest per capita healthcare cost in the nation. Only Miami, Florida was higher. The author of the article traveled to McAllen. He described how financial incentives affected medical culture and drove up cost. He called for a more patient-centric model of care, like the Mayo Clinic, like the Cleveland Clinic. Every pundit in America weighed in on McAllen's story. President Barack Obama read it and liked it, and it became required reading in the White House. The article won the National Magazine Award for 2010. It continues to influence the debate on healthcare reform across the nation. The author is our guest today, Dr. Atul Gawande. Dr. Gawande was born in Brooklyn, New York, and grew up in Athens, Ohio. His mother is a pediatrician and his father a urologist. He graduated from Stanford University, won a Rhodes Scholarship, and took a master's in politics and philosophy at Oxford University. He earned his medical degree at Harvard Medical School and did his residency at Brigham and Women's Hospital. He had a long interest in politics. As a student, he volunteered in 1984 presidential campaign for Senator Gary Hart. During a break from medical school, Atul Gawande became a healthcare lieutenant in the presidential campaign for Bill Clinton. He went on to become a senior advisor in the Department of Health and Human Services in the Clinton administration. He directed a committee in the Clinton Health Care Task Force and helped define the administration's health reform proposal. Dr. Gawande began his journalistic career as a resident. He began with a regular column in the online magazine Slate. The New Yorker published several of his articles and made him a staff writer in 1998. He wrote more than 25 articles for the New Yorker before his landmark story on McAllen, Texas. The topics range from the pain perplex to solitary confinement. His articles also appeared in the New York Times, the New York Review of Books, and many other publications. His first book was Complications, a surgeon's note on imperfect science. Hard to believe that surgeons had an imperfect science, but that was published in 2002. His next book, Better, a surgeon's notes on performance, came out in 2007. Both books tell powerful stories of patients and caregivers and make nuanced observations about quality and safety in the healthcare environment. Dr. Gawande's most recent book, the Checklist Manifesto, How to Get Things Right. The book's main point is simple. No matter how expert you may be, well-designed checklists can improve outcomes. He quickly made the New York Times and the Wall Street Journals and every other bestseller list. It is one of the most talked about medical books of the year. Dr. Gawande completed his surgical residency at Brigham and Women's Hospital in Boston and joined the faculty as a general surgeon and endocrine surgeon. He's also an associate professor of surgery at Harvard Medical School and associate professor in the Department of Health Policy and Management at Harvard School of Public Health. He's published research includes studies in surgical technique, military medicine, and medical errors. He's the director of the World Health Organization's Global Challenge for Safer Surgical Care. In 2006, he received a MacArthur Genius Grant for his research and writing. Dr. Gawande lives in Newton, Massachusetts with his wife and 3 children. A brief video will tell you a little bit more about him.
The knowledge of medicine, the power of words, the ambition to make a change. Atul Gawande, a physician with a unique combination of surgical skill and dynamic writing ability, instills the motivation to improve patient experience. He has demonstrated the power to change minds, change systems, and affect the cost and delivery of healthcare nationwide.
Please welcome to the show, Atul Gawande.
Today we spend the hour with one of the most influential health policy writers in the country.
Please welcome Dr. Atul Gawande.
His article in this week's issue details a revolutionary approach to slashing medical costs.
Using the power of media, Dr. Atul Gawande brings an understanding of complex issues to clinicians, policymakers, and patients worldwide.
He has emerged as an important voice in the debate over health care reform. His articles have become required reading in the Obama administration.
There are 1,000 ways that things go wrong in a complex world like in medicine.
Dr. Gawande brings to light what many in the medical community are calling one simple remedy to manage the extraordinary task of better, safer health care.
What you have done in terms of standards for doctors is this whole idea of checklist.
Using a checklist, they reduced infections 2/3, saved 1,500 lives in the first year. Our surgery checklist, we cut deaths by over 1/3 in the first 8 hospitals that began adopting it.
His vision for the future has global reach, implementing new systems, new concepts, and new ideas for improving care. Dr. Gawande understands the culture of medicine, reveals the inner workings of hospitals, and investigates the mysteries of cost, disparities, and regional variations in care. Compassionate, determined, clear, and detailed, he is the Surgeon General of medical journalism, the voice of a generation, making healthcare more transparent and effective in every way.
Please welcome Dr. Atul Gawande.
Well, that was incredibly flattering, and I don't know quite how I'll live up to that person. I want to start with a disclaimer, really. And I think if this is working, I'll be able to walk away a little bit. I've gotten lucky. I've gotten lucky about being able to write about what the experiences of trying to navigate the process of becoming a doctor and then trying to become really good at what I do, and have people interested in it. And I'm not exactly sure how it happened, but all that really happened was that I was starting to think hard about what it means as I was beginning to train to become a surgeon, what it means to be really good at being a surgeon. And that led to lots of questions I didn't find answers to in textbooks. Questions like, why do we make mistakes? How important it was that I learned from mistakes and from practicing on people. And then puzzling over how we cope with the questions of how we become really good at what we do as a whole group of people trying to work in this very difficult area, saving people's lives and improving their lives. For better or for worse, I've been able to become a surgeon and a writer, and I think one of the things that they have in common is that you're interested in the lives of individuals and what happens to them. And one question that I've been trying to ask myself is, who are we trying to help as we try to think about what our own institutions are trying to do in healthcare, what is trying to be accomplished in healthcare reform, and just on the very simple level of who we're trying to help as individual clinicians. And I think they're very closely tied together, although we don't necessarily feel it every day. But I met a man who helped bring it home for me. He was a middle-aged car mechanic. He had had trouble. He was married. He had been working just fine, and then he started to develop some severe abdominal pain The pain would come on whenever he ate. It would radiate throughout his abdomen. And because it would come on when he ate, he ended up with a 25-pound weight loss. He then started to have some ankle swelling. He did not have a regular doctor that he saw. And so after one of these attacks was particularly severe, he went into the hospital. He got some pain medication, got some imaging. The pain subsided. They suggested he go for an elective surgical consultation. He had no insurance. Because he could not pay for the consultation, no one would see him. And so another attack would come, and when it was severe enough, he would bounce back to the emergency room, again get the same round of imaging, some pain medication, the same recommendation to go for an elective surgical consultation. None of this was really working. He would have potentially paid for the surgical consultation, except for the fact that his wife had had an ER visit herself and ended up being diagnosed after all of the rounds of diagnosis with an acute cholecystitis that led to an operation, and the costs of the operation were more than they earned in a year, and they were already trying to figure out how to pay back those bills. So he wasn't about to add onto those just for an abdominal pain. He turned up a few months later in shock, however, in an emergency room, this time with a gangrenous segment of bowel and a bowel perforation, florid sepsis, a long stay in intensive care from what turned out to be a mesenteric ischemia, a cutoff of blood flow to his bowel for a rare condition, a Takayasu's arteritis, something your cardiologists have a great deal of experience with. The question I would ask you is, would it matter if I told you that I saw him in a district hospital in India? Would it matter if I told you that I saw him in a city hospital in Amman, Jordan? Or would it matter if I told you that I saw him where I saw him, which was in an emergency room in Boston, where he had come as an insurance refugee, as I would call it. He was from Alabama, had gotten his care there, could not get the care he needed. He had a relative in Massachusetts. In Massachusetts, about 3 years ago, under 3 years ago, we adopted a health plan very much like the one that is being attempted to be introduced around the country, that has provided nearly universal coverage. And under that, he was able just a few weeks earlier to get insurance coverage, but not quick enough that he'd been able to get to that elective surgical consultation. Every country is struggling desperately with healthcare and how to afford it, how to make it possible for their citizens to be able to get all of the capabilities that places like this have discovered and been able to deliver to people. And what we want to say is that the failure to be able to make it work and make it affordable for people, make sure that it is the kind of care you and I would want. What we want to say is that the problem is, in its roots, government regulation. Or we want to say it's the problem of markets. It depends on your political persuasion. But I think that the answer, the roots here, go far deeper. And they're far deeper than money or regulation or our difficulties with malpractice lawsuits or all of bureaucratic rules trying to deal with it, whether it's insurance companies or government medical programs. The deepest struggle that I think we face day to day in medicine that people don't necessarily understand is that our problem is the complexity of medicine, the increasing complexity and our difficulties in trying to deal with it. A century ago, we were just beginning a new century, like we are now. And where we were then was a place where we didn't understand what really happened to people when they got sick. We didn't understand why we became sick or how to treat most of the conditions that people had. And there was a revolution that started to occur around that time, started by people like William Osler at the Johns Hopkins Medical School, where what they began to do was pay very close attention at the bedside to the symptoms that people had. They would write down, Osler would write down very carefully the descriptions of what they were experiencing. And then when they died, because they didn't have treatments, they would open them up at autopsy and look inside and make connections between what they had seen at the bedside and what they found inside them. And slowly, one by one, they began enumerating scientifically all the conditions that human beings experience, all the ways in which the human body fails. And then once they had enumerated them, they began tackling with science for generating solutions for those problems. And we've inherited that accumulated science of the last century that's come from that. So that by the start of this century, we now have enumerated more than 13,600 different diagnoses, 13,600 ways that the human body fails. How do I know that, by the way? Pick up an ICD-9 procedure coding book. Now, I understand you're all on salary, so you don't see these things anymore. But we do. And if you count up all the ICD-9 coding diagnoses in there, it tells you all the conditions that have been discovered. 13,600 diagnoses, and we have treatments for virtually all of them. We cannot cure all of them. But we have ways to improve people's lives, reduce their suffering, help them live, to do the things that they can within what nature will allow them. But what do those treatments require? It's now 6,000 different drugs that I'm licensed to prescribe, 4,000 medical and surgical procedures that medical institutions try to provide. And what we're trying to do in medicine, in healthcare as a whole, is deploy these abilities, town by town, to every person alive. Do it in the right way, do it in the right time, without mistakes, without wasting resources, and with some degree of human compassion, some kindness. And is it any surprise that this is hard? I would argue that this is the most ambitious endeavor that mankind has ever attempted. There is no industry that has 13,600 different service lines that we try to deliver in every single town in the country, let alone the world, and do it effectively. I would argue that we're fooled by penicillin. 1929, penicillin was discovered. By 1945, we'd learned how to mass manufacture it and begin delivering it around the country, if not the world. And it was received in our communities as a miracle, because it was. Right? Here was this treatment that could eliminate a whole class of different kinds of infections, a whole class of whole diseases could be eliminated with this one treatment. But the second thing that made it a miracle was the fact that it was so easy. It was just an injection, and you could make it go away. And it fooled us into thinking that this was the future of medicine. The hard part was discovery, that the easy part would be execution. We imagined that there would be an injection for cardiac disease, an injection for cancer. And instead, it has turned out to be nothing like that. Any one of those treatments that we try to deliver on ends up taking enormous amounts of technology and work and risk and difficulty and skill. Our difficulties are only compounded by the fact that people never come with these diagnoses one at a time. They seem to come piled together. 5% of Americans account for 60% of our healthcare costs because they are sick with a variety of different illnesses, some of which you've never seen paired together in that way. Yes, a cardiac disease, and then a cancer diagnosis, and diabetes, and then this strange illness of Takayasu's arteritis. How are we going to handle that one? What we've arrived is in a place where an individual physician cannot do it. The amount of knowledge, the volume of capability has exceeded the capability of any single clinician to be able to know it all, to do it all, and do it at a world-class level, or even do it at an ordinary level. One of my colleagues, who is a physician who ended up rising in the ranks at an academic medical center, decided to ask a pretty simple question, which was, in the year 1970, how many clinical people did it take, how many people touching the patient did it take to take care of a patient? And the answer in 1970 was 2.5 FTEs, 2.5 full-time equivalents. And then he asked, in the late 1990s when he was looking at it, how many people did it take now? What he found was it was 19.5 FTEs. And it probably has increased since then. No individual can do it. It's now a place where organizations and systems are required. But we've never come to grips with that. We haven't quite recognized it. The signs of the difficulty stemming from the fact that medicine has become so complex are all around us. One sign is that man I told you about. It's the sign of a system that has been unable to wrap around and assure that a citizen could be provided basic care, essential care that could help them live and contribute to society. A second sign is that studies of all kinds have now shown that if you go into our communities and ask how well we provide care for people, the numbers aren't good. 40% of our coronary artery disease patients in our communities receive inappropriate or incomplete care. 60% of pneumonia patients and stroke patients and asthma patients receive incomplete or inappropriate care. 90% of patients with severe mental illness receive inappropriate or incomplete care. A third sign of the difficulty of managing all of this complexity is the worldwide cost explosion. The worldwide struggle, not just in the US, but in every country, with the fact that the costs of healthcare for their populations are outstripping their economies and forcing hard, often bitter, politically divisive debates about what we are going to do about it. Now, we in medicine have mostly been watching these arguments from the sidelines with a degree of bafflement, maybe even indifference to that process. We want to say, this is just the way good medicine is. But we're increasingly aware, I think, that we'd be ignoring the facts when we say that. There is a bell curve for care. There is a wide gap between those who get the best results and those who get the worst results, depending on where you are, what health system you're in. And the vast majority of health systems provide results that are in the mediocre middle, whether you're talking about cardiology outcomes or that asthma care or other things that I mentioned there. And what's interesting is there is also a bell curve for costs, depending on the health system you're in the United States. And the fascinating thing is they do not match. The people who get the very best results are not the most expensive places in the country. They're often among the least expensive. And that, to me, means there is opportunity. There is a chance to learn from the positive deviance, a chance to even save the economy. Because the alternative to that if the curves matched, if the best care is just the most expensive care, our only alternative then is rationing. And we just would have to face that hard reality. But it is not the case. There's an emerging lesson out of this, which is that for the most part, our health systems in the United States function under pretty similar rules. They are not ideal rules, but they vary enormously despite whatever the rules are. And that has taught us that healthcare is like politics. All healthcare is local. And where we are interested are those places that end up being most like a genuine system of care. They ensure that what people receive is care that is coordinated among those 19.5 people who are involved in taking care of them, where the care is meshed and works towards the goals that patients themselves have, that we ourselves have when we are sick or in need of care. A system is going to be most successful that can do those things. And a system is simply a place where diverse components fit and work together in concert. It's like a car that way. Great components are not enough. One of my colleagues, Don Berwick, now the head of Medicare, has pointed out that picking great components as your primary priority would be a terrible way to build a car. He gives the example of a famous thought experiment where you try to construct a car from the best components you could find. You could even do a randomized trial on each of the components, and they might tell you that the best brakes are a Ferrari brake, and the best engine is a Porsche engine, and the best chassis is a BMW chassis, and the safest car body is a Volvo, and you can put it all together, and what do you get? You get a pile of junk that doesn't actually go anywhere. A very expensive pile of junk that doesn't go anywhere. And does that sometimes sound like us in medicine? A system in the end has certain skills. And what you're working at Cleveland Clinic, and what I think many, many places across the country have woken up in the last couple of years and realized, is that they have to develop those skills. They have to develop those capabilities that systems have. One skill number one, is the ability to recognize failure. This is hard. It is not just one-on-one knowing when you failed. It's an ability to know whether you as a system are succeeding or failing. Some colleagues of mine in Cedar Rapids, Iowa, decided to ask themselves a failure question. They wanted to know how many CT scans had they done for their community. First of all, it was interesting that a group of doctors would ask this question, but they did. They had a community of 300,000 people. It took an enormous amount of work, and it's a sign of not having a system that it took them 3 months to figure out how many scans they'd done for the previous year, to get all of the insurance information together from all of the insurers that are involved in a community and the different providers and so on, but they figured it out. In a community of 300,000 people, they had done 52,000 scans, CT scans, in the previous year. And they were embarrassed about that. In virtually all of our communities, we've had very little ability to be able to track, not just as a health system, Cleveland Clinic or CASE or other places, but as a community in Cleveland. Are we doing better as a system of care for our community, or are we not? Skill number two is then to be able to devise systems, solutions, innovations that can help produce better results on those failures that you're monitoring. I spend half of my time in the operating room, but I think, like many of you here who are clinicians, you divide your time between how you spend your time in your clinical work and how you spend your time outside your clinical work. You come to special places like these because you want to make a difference, not only by being skilled one-on-one, but by finding ways to reach other people and connect and help shape things. And so you make a bet. All of our careers are gambles. They're a bet on the way in which you, with your own personality and what you do, can make a difference and enjoy it along the way. And so outside of surgery, I've gotten to spend my time in a strange way. One way is through writing, but I actually spend the minority of my time outside of surgery writing. The majority of my time is, of all things, on checklists. And it is the last place in the world I thought when I was going into surgical training I'd be spending a significant part of my time. But it became part of what I was doing when the World Health Organization asked me to help them solve a problem. And I don't know if we can flash the slides up. I have a few here. To a problem of wanting to try to reduce deaths in surgery. And as an individual clinician, this was something I had long been interested in. I wanted to know, how could I even begin to reduce deaths in surgery? And so this chance to help work on this problem on a global scale was absolutely fascinating. But the first fascinating thing was that the World Health Organization was even asking the question in the first place. Here's this organization that battles malaria and tuberculosis and HIV, and what were they doing worrying about surgery, of all things? But the answer turned out that as the world has aged, the volume of surgical care has exploded. People are surviving infectious disease and getting illnesses that require more complex care. And so the volume of surgery has now grown to the point that it has exceeded the volume of childbirth. The volume of childbirth is now close to 250 million operations a year, one for every 25 human beings, but with death rates 10 to 100 times higher than in childbirth. And suddenly, being able to take care of this problem was becoming a public health question. Now, our strategy was something of a puzzle. How do you tackle the question of deaths on a global scale in a field like surgery that's so complex to start with? We have two tools that we focus on in healthcare. We tend to focus on training and we focus on technology. But in healthcare, we could not train people longer. We could not give them more technology. And yet, we still fail. And so we decided to try to turn to other fields to understand what they do to cope with complexity. And we looked across fields like skyscraper construction, where drastic failure, collapse of buildings is incredibly rare, despite increasing and constantly changing technology. Or the aviation world. And again, what you see is they also rely on training, and they also rely on technology, and then they rely on one other incredibly simple-seeming thing: checklists. And so we decided to give it a try. The concept of a checklist is that it forces you to think hard about what it would mean to provide great care. And it leads you to start by, we actually involved Boeing's chief of safety engineering, who's designed hundreds of checklists across his career, learned how to make them work well in a high-stress environment of a crashing airplane, and convince pilots to grab a checklist when their life is on the line because they actually believe it could save them. And the answer that they told us was that if we wanted to take this idea to healthcare or other fields, we needed to analyze our failures. Then, having analyzed and enumerated our failures, then do an unusual thing I hadn't heard about. You want to identify pause points, moments in care when you can stop and run a few checks to make sure you haven't missed things. You want to then take the next step of identifying the best practices to avert key failures for each pause point. Gather information from the literature, if there are any, and if there isn't, go learn from lots of different places where the kinds of solutions might be. You want to distill that then into a practical checklist, and then you actually want to try it, and then retry it, because it never works. Whatever people cook up in a committee room never translates into the real world. We've been trying now, devising checklists for a variety of areas, and we found that we could not draft one in less than 50 revisions that people could actually find useful, that they didn't reject walking in the door. It was such a complicated process, we ended up making a checklist for checklists, which you can get at that website, by the way. But it turns out that in those other industries and worlds, they'd even identified what kind of font is easiest to see under high stress conditions and read well and not make mistakes. What we ended up devising then was a surgical safety checklist that has 3 pause points: before you've put the patient to sleep, before the incision is made, and before the patient leaves the operating room. And that allowed us to then distill what they call the killer items. The natural instinct, once you've made a checklist, is to pile on a whole list of every single thing you can think of, which makes it unusable. We sat there with stopwatches trying to see if it could be done in a minute or less. And what we found was that there were interesting checks in addition to the dumb checks. The dumb checks are things like make sure an antibiotic is given, make sure you have the right arm that you're operating on the body, make sure that blood is available for the critical high-risk case. But then the interesting checks are things like make sure everybody knows each other's name in the operating room, because there's often new people there, and unless they've been given permission to speak their own name out loud, they don't feel they can belong there, let alone say something if they have a doubt about what's going on. Make sure that the surgeon briefs the team on the goals of the operation, how much blood loss there is, any equipment that they think needs to be available. Have the anesthesiologist talk about the plan for the operation, for the anesthetics. Make sure they've discussed the medical concerns of the patient. Make sure the nurses have reviewed the sterility, equipment, and any other concerns they have. We then put these into test sites, and it turned out that's complicated too. You've learned this because you've been trying some of these ideas yourself. Peter Pronovost of Johns Hopkins calls these the 4 E's. You engage, you make sure your system is actually prepared by having the whole team come together, including administrative people who often have to clear the way to make it possible to try to get on the same page about what it is you're defining as great care. Then you have to teach people how to use these kinds of tools. As simple as they are, it's a different way of doing things. You execute, and then you evaluate. In our study, we began with 8 sites around the world. We deliberately picked places from some of the highest performing places around the world. University of Washington Medical Center, where they've had consistently positive outlier results in having low complication rates. Toronto General Hospital, St. Mary's Hospital in London, University of Auckland in New Zealand. But then in a crushed city hospital in Delhi, in rural Tanzania, where a simple infection after an orthopedic procedure can require an amputation because of inability to treat it well. And what we found was that in every hospital where we implemented the checklist, there was a reduction in complications. The average reduction in complications was 1/3. The reduction in deaths was 47%. The study was criticized. We did not have a control group. How do we know these changes weren't going to happen anyway? We had compressed this to happen in a short period of time, so we didn't think it was just a secular trend. We had lots of defenses against the idea. We had few countries that jumped on board. The United Kingdom implemented in all of their hospitals, Ireland, France. But another line of criticism was the fact that in a place like the United States or other wealthy places, we only had 4 hospitals. Maybe the low and middle income hospitals were where all of the improvement was. But in fact, we had a 30% reduction in complications in the high income hospitals. And then about 1.5 years later, we've had 2 recent papers from independent groups, the VA system and a Dutch system. In the Netherlands, they implemented a surgical checklist approach to care and arrived at almost eerily identical reductions a 47% reduction in deaths in the Netherlands, compared this time to a strong control group. And then in the Veterans Administration system, they showed that they could implement the World Health Organization checklist at scale and produce an average 18% reduction in mortality rates compared to controls. The idea has been spreading. We're in about 25% of American hospitals at this point, and I was really proud, sort of stunned, to go down to your operating rooms today with your teams and see just how much you had taken this to heart. A neurosurgical team that caught that a piece of equipment that they absolutely needed wasn't even clear it was in the hospital before they put the patient to sleep, and could catch it, make sure they did have it, put the patient to sleep. But the one that really impressed me was it was a neurosurgical procedure and the patient had a special request not to shave their head. And their neurosurgeon had thought he had a way that he could do that. And often that doesn't get communicated. The patient just gets put to sleep and the head gets shaved, and then you arrive down and you go, oh, I didn't want to shave your head. But you know, the patients remember these things. They matter. And they caught it, and they didn't even notice, I don't think, that they were making this kind of personal care really work. And that's the sign of a transformation. It's so routine, you don't even notice it. The concept is that we're defining what great care is and then figuring out how to deliver it. It shouldn't be as either complex or controversial or strange as it seems. Imagine we had a drug that could cut deaths 40% from surgery. It would spread faster than Viagra, which took about a 6-week rollout. And we wouldn't be trumpeting a 25% rate of hospitals adopting an idea that really should be everywhere. And there are deeper issues that are really here. The signs of major resistance you can see in places that have begun adopting ideas like checklists. Here is from a company that has made an electronic form of the checklist that pulls it up on screens, and then the teams click through it. And one of the interesting things is you can then see when they click through it, which gives you a read of whether it's really being adopted. And in these hospitals that are trumpeting the fact that they've adopted the checklist, they're in the 25%. You can see that the before incision check, which makes no difference once the incisions happen, you have about 20% where it's done after the incision. And remember, you're clicking through the checks, so it's not like this is documentation, this is actually going through the checks. And then you see some cases where it's done up to 2 hours before the incision, which just meant that the nurse is clicking through it because it's seen as a cultural barrier rather than the way that they do things. Learning how we make this part of our culture is a struggle. What I realize is that slowly over time is that it's a struggle because there's a set of values in the concept of a checklist or in the concept of making systems work. When you use it, there are 3 values that you are implicitly endorsing. One is humility, the belief that you can fail, that no matter how smart you are, how well trained, how excellent, that you are only human and you will fail. Our brains are flawed. The second value is discipline, the belief that one way you overcome that failure is by doing it the same way every time, making sure the basics happen in a disciplined way. And the third belief, the third value, is teamwork, the belief that other people, by engaging them, by including them, by communicating them with them, they can help save you and therefore save the patient. And when those values aren't there, that's where these don't succeed. Now, we have enormous potential for concepts like these, not just in surgery, but beyond. We have the possibility in ER care. We have the possibility for dealing with critical events, and we're now trialing a series of checklists for everything from cardiac arrest, air embolism, anaphylaxis attacks, whether it's in operating rooms or ERs. You can apply it to childbirth, where we've unrolled a process looking at a series of checks to avert key failures that we observe again and again as causes of avoidable deaths for mothers and newborns in low-income countries. And we'll be unveiling the results of a trial of a WHO checklist for childbirth that we've been testing in India very soon. But I think there's a further set of ideas behind this, which is that this is just reflective of the skill, I said that second skill, of being able to solve the key problems that our systems have in being able to deliver on care. So the first skill, I said, was being able to recognize failures. The second skill is to be able to find solutions to those failures. And I think one of those solutions that we're going to find again and again is yes, training, yes, technology, but often checklists as well. And then the third skill is going to be to find a way to knit them together into a portfolio that actually cuts costs. We have not had a single health system in the United States that has ever actually reduced the cost of care. Not in a little pocket, but actually taken the cost of care for patients as a whole and reduced those costs. As we begin to figure out how we can do that, it forces you to try to prioritize what are the parts of the system that you want to work on most consistently to make it better so that it could be lower cost care. And one of the most fascinating people I've run into in recent years is someone I wrote about recently in the New Yorker named Jeff Brenner, who is a young family physician in Camden, New Jersey, one of the most expensive communities in the country, desperately poor, high crime rate. And yet even there he has said, we can solve problems. And the way he did it was by taking seriously that idea that 5% of patients accounted for 60% of costs. He went further, he found that 1% accounted for 30% of the costs, and he said to himself, that's just 1,000 patients. That's about half the size of a family physician's practice. And he said, I'm going to make a team that we're going to take care of those patients. And one by one, he picked off the patients who were the most expensive patients in the community. He made a map looking at emergency room and hospital visits for the city and identified which areas were the ones with the highest cost patients. He found the two most expensive buildings in the city. This building had $16 million in receipts, about 6 times that much for the total charges, and a nursing home that was also similarly the highest concentration areas accounting for the largest bulk of the healthcare costs there. And his premise was the people with the highest costs are receiving the worst care. And time and again, it's proved true. Those 1,000 patients have had 39,000 emergency room and hospital visits. Their range was between 24 and 324 emergency room visits over the period of time that he watched them. They had over $375 million in charges. The receipts were enough that just for those 1,000 patients, they could have funded 50 family physicians or 100 nurse practitioners. With 3 people, himself, a social worker, and a nurse practitioner, with 3 people, he was able to cut their costs 56% and improve their care. What he did was he recognized that there are a few basic themes that you can find in the highest cost areas. If you recognize that those people are not receiving great care, if you focus on who your top 5% are, you'll find they're probably, like he found, an issue of patients with a conglomeration of chronic illness who needs much better, closer, high-touch personal care so they're able to stay out of the emergency room and stay out of the hospital. Number 2 is that they have to be able to solve problems of catastrophically expensive procedures, one-time procedures, whether it's for cancer care, trauma care, but there are ways to be able to take seriously the idea that we don't need to have them as expensive as they are. And the third is in terminal illness, in taking care of patients who have incurable disease, where we can do a great deal, and yet we fail time and time again to help them meet their greatest goals of care, which is not just to live as long as possible, but to avoid suffering, to be with their family as much as possible, be at home and capable. A randomized trial at the Mass General Hospital in Boston with advanced lung cancer patients had them see palliative care early in care rather than when crisis had already struck. And those patients ended up getting less likely to get that fourth round of chemotherapy or radiation, less likely to end up in the hospital when they died, less likely to die in the intensive care unit, at lower costs, less suffering, improved results for their caregivers, and they lived 25% longer. We don't provide good terminal illness care, and I know we can do better. In field after field, system innovation will save people. It will save costs. And I think it will save our economy. I think where we are now is in a battle for the soul of medicine. When we ignore the fights going on in politics and in Washington and think we are going to stay away from all of that, I think we're making a mistake. We are being asked to help lead where they are not going to be able to lead. The only way we know how to deal with the complexity of the science of what's been discovered and all that we try to pull off is if we help solve these problems, help make reforms to improve the quality of care and lower the cost in our own backyard. If we can make one health system that genuinely lowers costs without harming a single soul, the rest of the country will follow. You're in a very special place. There are very few places that have the capability of thinking hard and executing on becoming a system of care that can be a model for the entire country. And I've seen what is possible here. I'm visiting today to come lecture, but I'm also visiting today with my parents who are patients of yours here. My father is one of those people that might be in the top 5% of your healthcare costs. He developed a astrocytoma of his brainstem, and you all last summer did a heroic operation to make him free of pain and quadriplegia that would have claimed him by now. You helped him through radiation, and yet we still have a tumor that is continuing to grow and cause problems. I need to believe that great care for him will not bankrupt my own children's future. I need to believe that this does not have to trade off between taking care of him and ensuring that our economy has enough money to make great schools, to make a state that works, that can make thriving industries and other people. You're in one of the few places working hard and taking seriously this question of how we can make sure we can provide great care while also learning that we are capable of lowering costs. You've got extraordinary leaders, but more than that, you have extraordinary innovators at the bedside. So I thank you, number one, for the care you've already shown, the personal service, the caring. I thank you even more for all that you're going to do for my own family, for the state where I grew up and care a great deal about, and as a model for the rest of the country. You're going to be one of the places we all need to be. Thank you. understand there's some questions and microphones.
Hi, Dr. Gawande. I just want to, of course, thank you so much for being here. We're all so delighted to have you. My name is Laura. I'm a communications manager and a writer for the clinic's Education Institute. And I'm just curious to know who some of your favorite authors are and how they have influenced your writing.
So I have a mix of really favorite authors. Some of my favorite authors are physician authors or medical writers who've made it seem like you actually can write while being a physician. And those are people like Lewis Thomas, who became the president of Memorial Sloan Kettering, but as a medical student used to both sell blood, he would donate his blood, and write poetry for the Atlantic Monthly. And he lived in the time when you could make money selling poetry and selling your own blood, so it was a different era. Oliver Sacks, the surgeon Sherwin Newland. But the writers I most aspire to and most admire are probably George Orwell and Ernest Hemingway. Farewell to Arms is almost a third of it takes place in the hospital, and I've never seen a better encapsulation of what it's like to be a patient and have your own personality, and it's just withering on the surgeons. And George Orwell, who understood the moral dimensions of what we write about and how it can matter.
Hi, Dr. Gawande. My name is Maina. I'm one of the orthopedic surgery residents. I have a question about the checklist culture that you're trying to promote. The aviation industry was successful, and the construction industry was successful, and now we're trying to do the same thing. And you saw the ORs, and we're trying to take people from the normal state of affairs to going through these checklists. And it seems like that's the most difficult thing, to convince people that it's worth doing the checklist. How do you plan on going about this undertaking? Obviously speaking here and doing these sort of visits, but what else is going on to promote that culture of checklists?
Yeah, I mean, part of it is also is simply to recognize that the goal is not the culture, is not the checklist. The goal is great care. And achieving great care, if we understand that we will fail, if we understand that we're trying to make a whole complex group of people be able to work in the same direction for a person, we're mainly looking for tools and ways that we're able to ensure we're able to execute on it. I think it requires us to embrace a new concept of greatness. That is, being great at what you do is simply not possible without the basic kind of organizational tool of a checklist, because we just can't hold it all in our heads, and we can't create great teams without being on the same page doing these things. And I hearken to the example of the famous flight that Sully Sullenberg landed on the Hudson, with the Miracle on the Hudson, the U.S. Air jet that went out, lost both engines at about 3,000 feet over Manhattan. And what was interesting was that the public response afterwards was that, oh my God, you, Sully Sullenberg, was such a heroic, skilled pilot. How did you land that plane? It must have had something to do with the fact that you had flown gliders when you were a teenager and just had that experience under your belt. And he said, actually, no, it's nothing like flying a glider. It's like flying a brick falling out of the sky. We succeeded because of teamwork and discipline. And everybody said, he's just being modest. But in fact, when you dissected what happened, what you realized is it was both. Before the plane took off, they ran their checks. They checked their instruments, they checked their gauges, but they also checked that they went through a discussion they have every time, which is a little briefing on what they would do if a disaster happened, like the engines going out. Who would take what roles? He was flying that day with a first officer he'd never flown with before. Between the two of them, neither one of them had less than 25 years of flight experience. And you would think that sounds great, but two people who are highly experienced, undoubtedly highly opinionated, may not always work together in the same direction. I don't know if you've ever seen that around here. But in Boston, sometimes we see this. And they arrived at the same page, so that when they hit the geese over Manhattan, they already knew what they were going to do. Sullenberg knew that his first officer would be taking the checklist and running to see if he could do the most critical thing, which is restarting the engines, seeing if the engines could restart. But the second thing was that he knew that because all of the other things were taking place, he could focus his mind on the one thing that there was no checklist for. Where am I going to put this plane? And that is the mix. The dumb stuff, the basic stuff is out of the way so all of you can use your brains. How do we bring that across into a culture? I think it's leadership. I think it's a combination of places like this that are showing that this is how you teach people, how you train people, how you make them successful. I think it's monitoring our results and looking for whether our failures are improving. And in every place we've been monitoring, there's been steady reduction of complications. We're now launching a project in every hospital in South Carolina to measure the deaths and complication rates across the state as we implement this approach in surgery. But we don't get anywhere if you also don't take the interest in the innovation of bringing it to other fields, because our team clearly won't be able to do it ourselves across 13,600 different service lines. There will be many more opportunities, and so you all are part of the answer to making it possible. There was another question, I think, at that microphone.
Thank you, Dr. Gawande. I'm Jean Theory, and I run one of our federally qualified health centers here in Cleveland. Actually, I have a health policy question for you. Recognizing that somebody's cost is someone else's revenue, and that health centers like the Cleveland Clinic are economic engines for our city and our region, how do you see that cost, that difficulty being resolved?
It's very interesting. The prospect of who is going to lead here is being battled among three different players. There are the insurers who think that they can make the changes and incentives that move us from fee-for-service payment to global payments, being paid for an entire episode of care for patients, and that they will be the drivers of healthcare change. There are the hospitals, which have the systems of care and the organization like Cleveland Clinic to be able to execute on things, but don't have the incentives quite aligned. If you reduce the number of people who come into your hospitals, you will lose money. And yet the success of American healthcare depends on being able to do that. And so hospitals are becoming more and more actively involved in wrapping up primary care practices and ambulatory practices and creating what are being called accountable care organizations, organizations that can share in part of the savings with insurers if they are able to cut costs. You would get 20% of the savings if you're able to drive it down. But the third player in all of this are medical specialty groups. Physicians in ambulatory care are among the least organized people, but they are rapidly joining into large specialty groups. And as they are taking incentives for being able to find the hot spots in care, help make sure the care is better enough that they are able to keep patients out of the hospital, they are the ones who make the key decisions with patients about whether they are going to get that CT scan, whether they're going to end up in the hospital, whether they're being told at 5 o'clock, come on and see me, or go to the emergency room. In many ways, if I were to bet at this point, I'm going to bet on the physician groups being the ones who are more rapidly able to make the changes. In Denmark, where some of these changes happened a few years ago, they went from over 150 hospitals now down to 70, and they think they'll be at fewer than 40 in the next 3 years. So you can bet the hospitals, if they were driving that process, would be fighting tooth and nail to make sure that they're never shut down. So as the knowledge of what great care requires is learned and then executed, there will be a battle royale. There will be enormous lobbying and demonizing those places that actually succeed and find ways to lower the costs, keep people out of hospitals, keep them healthier than they otherwise were. And I think we have to be willing to be on the right side of this equation. If you're a hospital that is able to attract people by being lower cost, by being able to learn how to do it this way, you will be the hospitals that are potentially the ones that are still standing. Thank you enormously, and thank you for everything here that you're doing for me and my family. Thank you very much. Thank you.
Well, there are more than one person that I need to thank. First of all, I need to thank the Doctors Gawande for being here today and for raising such an extraordinary son. Thank you very much. And secondly, Atul, I want to thank you for being here today, for raising our sights, and for all of the patients whose lives that you have helped save by your thought process and your writings and your speaking. Thank you for being here, and thank you for being our guests. We appreciate it. Finally, let me just remind you that our next speaker in this series is General Jim Jones, formerly National Security Advisor, who will be here on May 18th. And then in September, Ben Bernanke will be here to speak to all you financial aficionados. So thank you very much and have a great day.